Thank you so much, everyone. Before we begin, I would like to advise those participating that we will be recording tonight's session. Good evening, all. On behalf of Eastern Melbourne PHN and Banksia Palliative Care, I wish to welcome everyone to the Banksia GP Palliative Care Workshop Series, Delirium and the Use of Sedatives in Community Palliative Care. My name is Nicole Stark, and I am the Events and Education Coordinator at MFIN. And I'm also joined by Sonia, who is the Palliative Care Program Facilitator at MFIN. Now, I would like to start with an acknowledgement of country. Eastern Melbourne PHN and Banksia Palliative Care acknowledges the Wurundjeri people and other people of the Kulin Nations on whose unceded lands our work in the community takes place. MFIN respectfully acknowledges their ancestors and elders, past and present. In the spirit of reconciliation, Eastern Melbourne PHN acknowledges the traditional custodians of country throughout Australia and their cultural, environmental, and spiritual connections to land, sea, and community. We pay our respects to their elders past and present and extend respect to all Aboriginal and Torres Strait Islander peoples today. We recognise and value the knowledge and wisdom of people with lived experience, their supporters, and the practitioners who work with them, and celebrate their strength and resilience in facing the challenges associated with recovery. We acknowledge the important contribution that they make to the development and delivery of health and community services in our catchment. Some quick housekeeping. All attendees will remain on mute throughout the presentation. Please type any questions for our speakers in the Q&A box at the bottom of the screen, and these will be answered at the end of the presentation. Little bit about Eastern Melbourne PHN. The Australian Government established primary health networks to increase efficiency of medical services, reduce fragmentation of care, and improve health outcomes for everyone, especially for the most vulnerable. MFIN achieves this goal by improving access to existing services, commissioning services to improve health outcomes, and by supporting GPs and others to innovate and further improve local healthcare. We aim to improve the health of our community by ensuring people receive the right care in the right place at the right time. We thank you all for joining us for this valuable information session. General practitioners will develop valuable skills and knowledge to equip them to engage in meaningful discussions surrounding the management of delirium within the community. Furthermore, GPs will gain increased confidence in the judicious use of sedatives, working collaboratively with the Community Palliative Care Service to enhance patient comfort and well-being. I would now like to introduce our fabulous speakers. Dr. Chien-Che is a palliative medicine specialist consultant in Victoria, working at various hospitals and palliative care services, including Banksia. He also serves as a general practitioner on Saturdays. His mission is to enhance the quality of life for those with incurable diseases, and he actively teaches and supervises medical students and trainees to promote academic excellence and compassion in healthcare. Dr. Bonnie Liu is a palliative care physician and geriatrician with experience working in various hospital and community settings. She currently works with Banksia Palliative Care Service and Austin Hospital. She has an interest in community-based healthcare and endeavours to support patients in their transition through different healthcare settings in illness trajectories. Bonnie is also involved in teaching and supervision of medical students and doctors in training. Lisa is a highly experienced palliative care nurse providing palliative care support for over a decade across all areas of healthcare, including public, private, and community palliative care. In addition to her training as a resident nurse in 2010 at RMIT, Lisa recently completed the graduate certificate in palliative care through Melbourne University. As clinical practice leader of Banksia Palliative Care Service, Lisa supports and guides a team of registered and enrolled nurses. Her key roles include coordination of the care team and working with palliative care physicians to ensure clients receive timely access to palliative care support and symptom management. And on that note, I will now pass the mic to Dr. Bonnie.
Good evening, everyone. Thank you so much, Nicole, for that introduction. Just bear with me. I'll just share my screen. Can you see that okay?
Yep, you just need to click swap displays.
Sorry. Perfect. Thanks, Nicole. So welcome everybody to week 2 of our GP webinar series, really focusing on the role of GPs. And I know there's a lot of people from various settings as well, not just GPs, but also nursing and clinical nurse consultants as well in the audience tonight. So I guess we're all trying to work together in caring for our patients in the community. And so, as Nicole mentioned, joining me tonight is Dr. Chien-Lin, as well as Lisa Candia. So tonight's presentation is about delirium and the use of sedatives in community palliative care. Just a bit of an outline of what we're covering tonight. So a bit of background, clinical features, maybe some why does it happen, screening tools and management. Some of these topics probably many of you are familiar with, so I won't dwell too long on things. So what is delirium? We know it's quite a serious acute medical condition, and it affects people's mental ability, and it generally develops over a short period of time, hours or days. Probably seen the DSM-5 diagnostic criteria, which is outlined in A, B, C, D, E. A for disturbed attention and awareness, and as mentioned, it's a change from the baseline, and it tends to fluctuate over the course of the day, and there's disturbance in the cognition as well. And again, many of you are probably familiar with this table about the differentials for delirium, the 3 Ds. So we've got delirium, dementia, and depression. And this slide is really just showing, maybe the key features that might separate delirium from the other 2 diagnoses. So first of all, as mentioned with delirium, it's generally a more acute, or it can be a subacute onset. Alertness, people fluctuate, and attention in delirium, it tends to be impaired as well, and fluctuating too. And people can have quite disorganized thinking, distorted, be fragmented, slow, or incoherent. This question is, why does delirium matter? It's common, but it's not normal, and it affects quite a number of older adults each year. And you'll find a lot of this data, it's quite variable, and I think related to how well delirium is screened and recognised. So from the available data that I've looked at, prevalence can vary from 13 to 14% in palliative care units, and higher incidence in intensive care units. And I guess there's a lot of implications of delirium as well, and people can end up being significantly impaired on a long-term basis, and may need to even change their usual place of residence. And I think the thing is, a lot of a lot of people who do develop delirium, a lot of these cases are unrecognized, and potentially maybe up to a third or a bit more could be preventable. The delirium itself has a lot of impact for the patient themselves. It's frightening, especially those who recover from delirium and they retain some insight of what's happened. It's distressing, and there is that it is resulted with them having poor outcomes, whether it be increased falls, pressure areas, longer hospital stays, and also there is that mortality risk as well. And we know that if say in Australia, approximately 16% of people with persistent delirium, it does predict, it has an increased risk of dying. And I guess it does have longer term effects, such as admission to long-term care, post-traumatic stress disorder, and also that future risk of developing dementia too. But also for the family, it's distressing. You're observing your loved one experiencing what they're going through, and maybe you're not very aware of what's happening too. And also sometimes people are put in a position where they've never really had to make a decision on behalf of their loved one, but now they have that responsibility. And also for the health professional, it can be fatiguing. Quite a lot of care burden on health professionals looking after these patients with delirium, and it's also distressing. Observing people going through, especially a hyperactive delirium, because I guess as healthcare workers, we want to help people, and we don't really want people to be suffering. And I guess in the overall healthcare system, there are associated costs, especially with the length of stay and associated complications. So I thought I'd continue this presentation with a case and talk, and then we'll build it from there. But please, feel free to write questions or as we go, and we can address them later. So we've got the case of Harold, and he's a bit of a combination of cases from the past, but he's a 78-year-old gentleman, and the Community Palliative Care Service was contacted by his wife because he was reported to be more confused, especially over the past week, agitated and verbally aggressive at times. In terms of medical history, it's on a background of metastatic pancreatic cancer with liver metastases, and he's really not for further disease-modifying treatments, and other history including type 2 diabetes, heart failure, macular degeneration, and he's quite hard of hearing and usually would wear his bilateral hearing aids. So, so I guess pretend you're asked to visit the house to assess. What are the things you want to know? What do you want to do? So while we're thinking about that, I'll move on to some clinical features with delirium, which we have mentioned already about that it can develop quite acutely or on a more subacute basis, and people can present with disorientation, that reduced attention and concentration. They can have sleep disturbances, and just altered awareness of what's happening, very disorganized. And it can occur in the setting of them experiencing a severe medical illness. Just more features there. And you're probably all familiar with the delirium subtypes. I think most commonly delirium is mixed. Probably What we're more familiar with is the hyperactive delirium subtype, where it's a lot easier to recognize, where people are restless, agitated, they could be wandering, experiencing hallucinations, and I guess we tend to be more aware of it when there is any incidence of aggression, whether it be verbal or physical. It's the hyperactive delirium subtype where patients can be, I think this is where a lot of the under recognition occurs, because they're easily missed. Patients can appear quiet, a bit more, withdrawn, drowsy, and they might be diagnosed with something else, like maybe they're depressed. And I guess because we're not recognizing them as much, they can have worse outcomes. So I guess the question is, why does delirium happen? And this is a bit of a busy flow chart. So we've got precipitants of delirium, there's neuroinflammatory components to it, oxidative stress, neuroendocrine abnormalities such as glucose metabolism, cortisol, and neurotransmitter dysregulation, for example, increase in dopamine, noradrenaline, or reduce melatonin or acetylcholine. I guess in summary, there's lots of mechanisms proposed, but I guess we still don't really fully understand it. And I guess given that it's quite multifactorial, there's really no single pathway where medications can be used to target it. And it's likely a combination of many factors, including environmental as well. But it's also important to consider the direct brain insults too. So it's almost like if you can avoid it, that's probably the most ideal. Probably familiar with predisposing factors as well as the precipitating factors of delirium. And it's just a bit of just the flow chart as to some of the potentially modifiable factors, such as sensory impairment. In our case, Harold has macular degeneration and hearing impairment, so making sure he's got his hearing aids. And there's also non-modifiable factors such as an increased age, if people have pre-existing cognitive deficits, or they have multiple chronic medical conditions as well, and lots of precipitating factors. And probably for us at the top of the list is medications, and something we always have to think about when someone presents with delirium. I guess in palliative care there are additional risk factors, especially in our patients who have a malignant diagnosis, and potentially they are modifiable. But again, at the top of this list is really medications again, and we're probably at fault sometimes. Bit of iatrogenic prescribing with benzodiazepines, opioids, corticosteroids, and other psychotropic medications. But there are non-modifiable factors too in our patients who do have cancer, whether they have underlying bone metastases, liver metastases, or intracranial disease, or leptomeningeal disease, or even in any metabolic disturbances such as hypercalcemia. So we'll go back to Harold. So a little bit, you're in the house. We want to try and get a bit more history. So we've been told by his wife that over the past week he has become more weak. He's resting more in bed. She's noticed that he tends to be a bit agitated and verbally aggressive at times, and other times quite drowsy. So that real fluctuating course throughout the day. He's not really been eating or drinking, has been finding it difficult to take his medications, the oral ones. She hasn't noticed any problems with, with his bowels or his urination. There haven't been any new medications. He's pretty much just his medications have been previously rationalized, and he's just really on symptom-based management with a fentanyl patch as well as pregabalin. And when you assess Harold, you find that he's quite jaundiced. He's got the nodular liver as you expect, nothing else really significant. And I guess the question next is, what do you do next? What else do you want to know? Might move on to the screening tools that we can use in Delirium. And you've probably seen these. These are just the main four that I'll be talking about tonight. The first one is the single question in Delirium, or the SQUID. And basically it's asking, do you think the person has been more confused lately? And I guess the purpose of this is really trying to improve that early recognition and awareness of delirium. And then we'll move on to the CAM, which probably many people are more familiar with. And it is validated in the palliative care setting. It has a reasonably good sensitivity as well as specificity. And again, we're looking at those clinical features. Other one, I'm not sure if people have seen the new desk before, but basically it's a symptom rating as 0 to 2 with different symptoms of disorientation, inappropriate behavior, inappropriate communication, illusions, hallucinations, or psychomotor retardation. And if the person scores more than 2, then that identifies the presence of delirium. And it has a reasonable sensitivity as well. I quite like the 4AT because I find it a lot more simple to use, and you don't have to be trained in, say, in some of the other screening tools. And basically, if a person scores 4 or more, then it's suggestive of a possible delirium. And there's, at the moment, there's still research undergoing for the validation in the palliative care setting. But as I said, it's fast. There's no real special training, and you don't necessarily need physical responses. So it allows for testing of patients who previously, maybe say in the CAM, aren't testable. So we'll go back to Harold now. Yes, the impression is he's got a mixed delirium with no, and he doesn't seem to really appreciate what's happening, no real insight of his current situation. We're fortunate to know that Harold had, prior to this, appointed Judith, his wife, as his medical treatment decision maker. And he's also completed an advanced care directive. And in that is stated his values, his independence and quality of life. He only really wants treatment that can maintain this. It's clear that he didn't want resuscitation, doesn't want to be a vegetable. And he also expressed that his preferred place of death is home, with his family surrounding him. And you'll probably find with a lot of our community palliative care patients, we do review this with them on a regular basis about where their preferred place of care is, and on further discussions about where they want to be when they are dying. So I guess the next question is, how do we approach Judith with discussing the ongoing management for Harold? What might be some logistic or practical considerations? Like, how do you explain to her what he is experiencing? I guess there's a lot of factors to consider. emotional, spiritual, social, and physical considerations. And I think this is where the community palliative care.
Sorry, I can't hear you, Bonnie.
Chien, are you able to speak to this while I call Bonnie?
Sure, yes.
Thank you.
So we're moving on to management depending on the stage of the disease, and really talking about limitation of medical investigations and treatments. And there's a few things that's high yield. It generally involves a urine test, a blood test, some bedside tests. There was a question earlier about type 2 diabetes, and certainly a blood sugar listed there is very important, and making sure we review that it is managed, because of course hypo and hyperglycemia both can precipitate delirium, and making sure there are no easily modifiable factors. And how easily a factor is modifiable really varies case to case. And there are, of course, limitations of organizing investigations and treatments at home. And so oral treatments may be very easy at home, but certainly intravenous treatments are much harder. And really, when we order for something like calcium levels, the consideration is perhaps if there's no preference or plan to go back to the hospital, if the burden of going back to hospital is unacceptable to the person, then testing for calcium probably isn't something worthwhile doing while the person's at home. But if they're already in the hospital, certainly something we may organize, because we can treat it quite easily on the ward. But whether that's a good enough reason to come to hospital, it varies case by case.
Chien, if you want the slide to be changed, just say it out loud and we can change it for you.
Okay, great. Yeah, we might go to the next slide. Okay. So, so the underlying cause should be identified and treated where possible and appropriate. So we discussed that a bit, and that really comes down to three factors. So whether it's likely to be treatable, of course, with advanced malignancy, with brain mets, we certainly are not able to treat the metastasis itself. We might be able to treat if there's vasogenic edema around the tumor, but we certainly can't remove the tumor or repair the damage that tumor has already done. There are factors where the burden is unacceptable, and again, cancer treatments are probably the poster boy, because many people can't tolerate cancer treatment at this stage, and surgery is another poster boy. And but yeah, when it comes to things like medication rationalization, and also treating opioid toxicity, of course, we don't want the pain to recur, so we rotate the opioid rather than we stop the opioids or do naloxone. We can supply oxygen. We can treat with oral or IV antibiotics sometimes quite easily, and we can correct metabolic abnormalities with relative ease depending on the environment. But of course, the final consideration really is whether the prognosis would allow us to have recovery, because it does take a week or two for delirium to fully resolve. And when we talk about agitated delirium at the end of life, there is the possibility that people are not able to live for long enough for the delirium to resolve, even after we correct all the underlying factors. I might go to next slide. Sorry, can we go to next slide? So yeah, and the non-pharmacological aspect is arguably much more important, because when the person's delirious, we want to make sure they're safe, and there's no environmental factors that's going to prolong the confusion or perpetuate agitation. Making sure we normalize their sleep pattern. During the day, we try to open the windows, allow the sunlight in, and nighttime, creating a quiet environment at night. Have strategies to reorientate and reassure the person, because usually people can be quite anxious or fearful when they're confused and not sure, not able to recognize where they are. And relaxation techniques and education of the client and family and carers are extremely important, because it is a very distressing situation for family and carers, equally with the client, and to witness. And it's one of the commonest reasons people come to hospital, knowing that coming to hospital, a change in environment, potentially still may perpetuate the delirium. So it is a hard balance to be found. We do want to encourage activities during the day where safe, and ensure that pain is actually relieved. Hence, we talked about rotating opioids rather than stopping it. Using communication aids, and making sure someone familiar is involved in the care, and ensure they're remember to hydrate and remember to toilet. And yes, and making sure they don't have a fall or have other complications in the meanwhile. You can see the antipsychotic medication on the bottom right. It really is when we're not able to manage distressing agitation with non-pharmacological managements. And just remember, medications do not treat delirium and likely prolongs them, and they're used for the agitation. So I might go to next slide.
Thanks, Chien. Sorry about
you're
that,
back?
everyone. I'm not having much luck with technology tonight. But thanks, Chien, for holding the fort. And I think the next few slides is basically really just a bit more detail about what you've already discussed about the non-pharmacological strategies. So I'll skip through that. And you might have mentioned for families, because it's well in a situation, witnessing your loved one having, say, hyperactive delirium. Just having that written information is useful that they can go back to once once they've kind of tried to consider all the information you've told them already. So I guess we'll move on to pharmacological management now, and I think there has been a change over recent years about how we approach this, and really we try and reserve pharmacological therapy for severe behavioural disturbances, or if there's a severe emotional disturbance where the behaviour threatens their own safety or the safety of others. And also if the person themselves is quite distressed, or they're at potential risk of themselves or others. And if we are starting any medications, then we, as a general rule, we start with the lowest dose and then up titrate according to their symptoms. And this is similar as outlined in the Australian Delirium Clinical Care Standard about avoiding the routine use of antipsychotics for treating delirium. There is definitely a role of short-term use, especially when there, as mentioned, that there's that risk to patient and others. And if there is a plan to use it longer term, then to make sure that there is a plan for the duration of therapy and criteria as to when it should be stopped. And generally for delirium, we do avoid benzodiazepines, but you'll find probably in the palliative care setting, we do end up using them, especially towards the end of life. I might just skip through this, just mindful of time. But it's really just saying about, if someone is unable to make a decision, what are the options and who would be considered their substitute decision maker. You've probably seen that there is a little bit of a hierarchy that's outlined in the Office of Public Advocate. Skip this as well. But really it's just about, if we are considering starting things, including antipsychotics, unless it's a emergent situation, then it's important to have these discussions and with the substitute medical decision maker. But we'll go to medications now. So in palliative care, probably the haloperidol is the most commonly used. We generally avoid it in Parkinson's or dementia of Lewy body, just not to associate any extrapyramidal side effects. And potential alternatives can include olanzapine, risperidone, or quetiapine. But say for people with Parkinson's disease or dementia of Lewy bodies, probably more quetiapine, or we do use benzodiazepines as well. And what we do know is it doesn't, even though we use it, there doesn't seem to be a reduction in the duration of delirium, but it can impact, there is a potential harm as well. So that's why we do reserve it for people who are experiencing severe agitation, and having a really clear communication with everyone involved as well, and having a follow-up and monitoring plan in place. This is probably one of the most cited papers in the palliative care literature that challenge, that historical management, delirium management in palliative care. And it was an Australian study, Australian inpatient palliative care units, and where they found that people who were prescribed haloperidol and risperidone tend to have higher delirium symptom scores, and potentially a higher mortality as well compared to those having a placebo. And basically the conclusion was, the way of managing delirium is really having that individualized management of precipitants and supportive strategies, and that resulted in a lower symptom score. So it's just a table about the different antipsychotics and the side effects as well. I think quite useful, especially sometimes, is to try and work out which antipsychotic might be most appropriate in a scenario. So if we're trying to find something that's a little bit more sedating, then you might be more inclined for, say, olanzapine or quetiapine. But unfortunately, they all do have side effects. This next slide is really about benzodiazepines, and we do use them in palliative care for delirium, and as well as other symptoms such as sometimes nausea. But the commonly used ones are lorazepam, clonazepam, as well as midazolam. But there is that small risk of paradoxical reactions where people can become more agitated or disinhibited. And probably in that more acute setting, rather than acute where there's potentially reversible conditions, it's probably less evidence for effectiveness in non-alcohol related delirium. And there's obviously risk of falls and injuries. I might go back to the case of Harold. So I think after discussion with Judith, I think there was a clear recognition that Harold was approaching that end of life and really at risk of developing a terminal delirium. And Judith wanted to respect Harold's wishes to remain at home rather than a hospital transfer to investigate and treat. I think here, especially with his jaundice and the history she was giving of his decline, that this is probably all related to his cancer, and that even if he was to go into hospital for further investigation, it wasn't likely to improve to a level where he would have found acceptable. So that's this is the next step was really trying to set them up at home with the Community Palliative Care Service. Formally, this is where thanks to palliative care, we can organise hospital beds, more regular nursing visits, carer support, including carer training with our endorsed nurses to teach family members about personal care tasks, safe ways of repositioning, transfers if needed. And I think for Judith herself, she was quite fortunate. There was that Judith and Harold have children living close by, so they were able to provide some informal support, because otherwise a lot of that care would have fallen on her. And then we can also make referrals for Carer Gateway, and we do sometimes, especially towards that terminal phase, patients are eligible for, and you can correct me if I'm wrong, Lisa, but they can have up to 3 nights of a nursing, a nurse, I think it's for Paul and Claire, stay overnight, just to help from a carer respite perspective, and just for that care towards that end of life. And also there's obviously psychosocial support as well, because this is challenging. This is not something that's easy. It's confronting, and it's burdensome too on the carer. And I guess the important thing is to make sure that all the medications that might be needed to support end of life care are at home, including, I think Scott last week would have mentioned something for pain such as morphine, haloperidol, clonazepam drops, and yes, in Harold's case, we did organise midazolam as well, just recognising that he might need a little bit of sedation as well. So I guess that leads us on to terminal delirium, and that's really the development of delirium in a dying patient, and it's a poor prognostic sign, and it's usually refractory. And in these patients, especially if we know that they're going to, their prognosis is going to be quite short, and there's quite significant distress, we may need to use medications with some sedation associated with it to achieve that adequate relief of symptoms. And this is where you're having that team support and information provision for the family, but for all the care providers involved, as well as the services involved, is quite important. And this is just some of the medications we generally use in palliative sedation, such as midazolam, levomepromazine, phenobarbital. They're probably the main ones. The difficulty, I guess, in the community is sometimes accessing medications such as levomepromazine and phenobarbital, and also the associated costs, because a lot of the costs of medications in the community does fall on to patients, which is different compared to if they were in hospital. And these medications aren't really, they're not subsidised by the PBS. So we'll go back to Harold. So there was definite recognition there was carer fatigue for Judith, and the preferred place of care was revisited with her, and she maintained that she wished to have Harold home, but we always have that option, that there is always that option of a palliative care unit as well for inpatient management, and it's not really a failure of the carer. It's just more a reflection of the specialized needs and symptom management of the person. He was utilizing regular breakthroughs, so he started him on a syringe driver. He was a lot more comfortable, and he died 3 days later. So on that note, we might just finish there. It gives us a bit more time, but it matters. Delirium really matters, and because it causes a lot of distress to everyone involved, and there's an impact on prognosis. It may be reversible treating the underlying cause, if known, may be appropriate, but it's always a decision making about reversibility and people's goals of care and their preferences of care as well. But I think most importantly is to have that interdisciplinary approach, and combination of and individualized as well, and not a combination of non-pharmacological but also medications as well. But on that note, this is just the last slide, and I'll stop it there. About referring to community palliative care. So with Banksia, anyone can refer themselves, and it's a link through the website or by phone as well. So on that note, I might hand over to Sonia, and we'll come back to questions afterwards.
So much, Bonnie. So I'm now going to share my screen. All right, hopefully everyone can see that clearly now. So I'm actually presenting on behalf of Crystal, who is one of our program specialists at Eastern Melbourne PHN, about health pathways and how that might be able to help to support you with the assessment and management of your patients in the palliative care space. So I'm just going to move this. And
Sonia, can we turn that up as we can't hear it? Or did you want to just try resharing with the volume?
Okay, 2 seconds. Thank you. Sorry, team, while you're hanging there with me. I might just go back to my settings.
Yeah, so normally if you turn up the volume on your laptop and then share screen and hit the share with audio, you're good.
That better?
Yep, let's try sharing.
Sorry, everyone. We thought we had this down pat.
No, can't hear it.
Okay, that's all right. Well, I'll talk to it then. Hopefully I'll do my best to present on behalf of somebody else. Basically, this slide is explaining that Health Pathways is put together by Eastern Melbourne PHN and Northwestern PHN, and it's a resource for GPs and GP practices that can be used to help support you whilst in your practice. There are over 40 pages that can be used specifically for palliative care, and I'll show you some of those moving forward. Here you can see we have a multitude of different subheadings which you can go into. Unfortunately, I don't think the video will work, which we do have for you. But under these subheadings, you can see the assessment. We also have links that you can use that may be of assistance to guide your assessment and further information. So we have the general palliative care guidance and assessment tools. You've got your local community specialist care providers. So as Bonnie was just saying now, with regards to referrals, if you actually go onto the Health Pathways page and go under the Specialist Palliative Care Services and then go to the Eastern catchment, you'll actually find all of Banksia's details there, as well as how to refer through the Health Pathways. We also have a lot of information about the palliative care medications and essential conversations, which we know can be very difficult for all of us to have with patients and their families. So there is some advice there, as well as legal advice with regards to advanced care planning and wills, etc. There's some more pages here with regards to the symptom control. So the page such as the anxiety, distress and agitation may be of assistance following on from today's presentation, but there's other information that links to other presentations that Banksia will be doing, including emergencies in palliative care and different palliative care referral services that may be of assistance. With regards to this page here, if you haven't registered for Health Pathways, you can go to melbourne.healthpathways.org.au and create a registration code. If you have any issues with regards to registering for Health Pathways, please feel free to send an email to us at info@healthpathways.org.au, and we're also able to create an automatic login for your practice to make the process a lot easier. All right, thank you very much. And I'm sorry there was some tech challenges there. We've had a bit of a bumpy ride tonight, but I'll pass now back to Chien and he can get to our question and answers.
Thanks, Sonia, and thanks, Bonnie, for a comprehensive presentation, as always. And thank you all for attending. Now, I'll just go through the questions that I've tried answering in the chat to some degree. And so the first question was because we didn't go through the medications for his diabetes. And of course, yes, that is a very important aspect to optimize. And blood sugar levels certainly can be a risk and can be perpetuating delirium, and should be treated where possible. And I think the big point is people prone to hypos because they often continue the same dose of medications when they're not eating much at all. And also because there may be other reasons of pancreatic failure, like if they have pancreatic cancer. So it's important to make sure that's not what they're having. And in terms of hyperglycemia, BSL less than 20 is actually generally won't cause any additional symptoms, and we usually aim for less than 15, but we're not too strict on in terms of managing that. And yes, and Bonnie did add on that the case example, the medications have been rationalized. There was a question about VAD, so we didn't touch on that interface in this case. And certainly people please come to our talks. And our fourth one is the essential discussions that one of our doctors, Hussein, will be going through with everyone. So please stay tuned and join us, and we can go through that in a bit more detail. And in terms of, there was a question about someone can't tolerate antipsychotics if they have akathisia or agitation, even with third-generation antipsychotics. And this, of course, again, is when non-pharmacological management has been insufficient. And we probably would have to use more benzodiazepines in these cases. In terms of selection of antipsychotics, I think Bonnie, feel free to chip in, but we probably would use haloperidol first line for various reasons. It's the injections are tolerated well subcutaneously, which is a much easier route to manage at home than intravascular or intravenous, and it has quite a predictable onset time of within the hour. Tablets can be crushed and they come in liquid as well. And I think if there's history of especially Alzheimer's dementia, I think potentially people might use more risperidone in those cases too. But I think haloperidol generally is first line when it comes to delirium. Yeah, thanks, Bonnie. Yes, the dosing is 0.5 to 1 milligram. Yes, every 4 hours generally, and maximum of 5 milligrams per day. And in terms of the next question is, how do we prescribe phenobarbital if appropriate? Yes, they're not hard to source for community pharmacies. That is in comparison to some of the other sedatives we have. Clearly, pharmacies won't have them on the shelf all the time. So, but also they are third-line sedatives. The onset time and the duration of effect and all that is quite unpredictable for phenobarbital. In fact, we used to use it to treat anxiety before the benzodiazepines were invented. So benzos are clear superior agents, and antipsychotics certainly also are more predictable. So we won't be using them unless we have to when the other two lines of medications haven't been used or successful in managing the distress. And certainly specialist services should be involved, especially in suburban Melbourne. But also statewide, there are advisory lines, and we're all very keen to be involved in discussing use of sedatives in these settings, because these are extremely distressing settings where we have to use sedatives to manage agitation for the families, for carers, and also for other participating care providers at the time. So please either ring the statewide advice line or just contact the local community palliative care services, and these people will need additional monitoring as well. So make sure you involve the special services in that regard. So I feel like there was another question somewhere about selection of benzo versus antipsychotics, I think. But in a sense, I think agitation, we would generally use antipsychotic before benzos because they're less likely to cause tolerance, but also usually associated with less complications generally, unless there's contraindications before. I think one for me, if there's a strong component of anxiety from pre-existing history or just a situation, then I might use a small dose of benzos to manage that as well, because they probably do work better on anxiety. But otherwise, if it's undifferentiated agitation, I would generally use antipsychotic first line. Again, Bonnie, feel free to jump in if there's any different practices.
No, I think that's right, Chien. The only thing I'd add is, say, when we are prescribing anticipatory palliative meds, I might choose haloperidol over metoclopramide if I suspect this patient might be more likely to develop a delirium, just mainly with the anticholinergic
Yes.
component with metoclopramide. And possibly maybe in a patient with dementia who has BPSD and they're already on oral antipsychotics, I'd probably go with paliperidol as the anticipatory palliative care medication rather than metoclopramide.
Yes,
And,
I agree
and I
completely.
guess, yeah, we can use that for nausea, vomiting, as well as agitation if needed.
Yes, haloperidol is a very effective antiemetic, so so it's good. Yes, so that's all I have so far. So I hand back to Nicole to do the wrapping up.
Thank you so much for that. And thank you so much for your patience, everyone. We apologize for some of the tech issues, but appreciate you hanging in there. And thank you all for being a part of tonight's session. It has been an absolute pleasure to have you here this evening. I hope you've taken away some valuable insight. I'd like to extend a special thank you to our exceptional presenters for their fabulous work. By participating in tonight's RACGP accredited activity, you will receive 1 hour in educational activities. I will lodge those hours through the RACGP on your behalf. At the end of this session, a link to the workshop survey will appear on your screen. Please take a moment to fill in the event survey for your accreditation and also to provide some valuable feedback so that we can further improve these education sessions. Your responses are greatly appreciated. This is a 5-part palliative care in the community series. If you haven't already done so, please register yourself for the next session. Management of nausea, vomiting, and other palliative care symptoms in the community. It is being held on Zoom Thursday, the 19th of October from 7 p.m. to 8 p.m. This is another RACGP accredited session. You can scan the third QR code to register yourself for this virtual activity. Please also take a moment to check out other upcoming infant education events by scanning the middle QR code on your screen, and it will take you directly to our infant events page on the website, where you'll be able to find out more information about what other education workshops we have coming up. There will be a follow-up email that everyone will receive, which will include a copy of the presentations you have seen tonight, in addition to other relevant resources. You will also receive your certificates within the next 4 weeks of this session from MFIM. We thank you all for your time and attention this evening, and have a wonderful rest of the night. Thank you all.
Thanks, everyone.
Thank you. Good night.
Night, guys.